Good afternoon. XYZ, a turnpike breached by mischievous neurons. What a catchy phrase, isn't it? This phrase itself should attract more people coming, and I'm sure they'll trickle in. And I'm sure this phrase was coined by Professor Manjari. And it would, just to me, I think the world's best epilepsy team is here. Um, very proud and very privileged to say that to me, the last word. And I think she does keep getting, whenever I'm at a crossroads of what I need to do, I turn to her. So, and not just the neurology aspect, must be half a neurosurgeon by now. But then, then there's a whole lot of transdisciplinary, those boundaries which have sort of made into one global, holistic, and extremely I would say that amazingly advanced kind of technological just advances, and also the science behind it, understanding and moving forward. This kind of an upward mobility has been credited to this center of excellence. So, pretty proud. And so this is the team which is going to present to you about, as what Professor Manjari said, just getting an update on the role and how to use magnetic encephalography. And again, I guess whether MEG came here first or down south, I don't know, but I think yours is the first center which has really seen the advances in terms of using this machine too. So again, I will be leaving, but I must put on record and also congratulate this stupendous team. And I'm so privileged and honored to be a part of it. As part of it, as a colleague, not for a contribution, I take advantage and I take help from this team. Congratulations and inaugurate that.
Thank you, ma'am. And just 2 weeks back, my daughter asked me who was your best head of department. I said Professor Padma. So thank you, ma'am, for your encouraging words. You have always encouraged the work which we have been doing. And today we are going to talk about the basic principles, the mechanisms, and the utility of a highly advanced system which is available to us, thankfully. And so the title is XYZ, and I'll let you know why. So, what is a turnpike? How many of you know what is a turnpike? Out of curiosity, no one checked. Okay, so a turnpike was actually a term coined, way back in USA, where it was a barrier. It was a barrier so that people who are coming into the city or going out of the city would stop there, and they could regulate how many are coming in. They could check how many are coming in and how many are going out. And of course, the most important part of any government is to collect taxes. So that was a turnpike. Now, the turnpikes have evolved over time. Previously, they were just gates. And now they are kind of not just gates, they are just, pathways. And these pathways have a lot of channels because there's so many, highways and freeways everywhere. So essentially, the work of the turnpike was to halt everything, which is what, the neurons are. If the neurons are working in a regulated manner, you don't need any halting. But if the neurons are hyperexcitable, and in a milder term, I put it as mischievous, they are going to be not halted by the turnpike, and they are going to result in an inciting of the epileptogenic zone and the ictal onsets, which is what the neurologist is after in drug resistant epilepsy. So if you take this prototype of a subtle, left frontal cortical dysplasia in a center which any of you as a neurologist could start after you do your DM and go, you would look at the clinical phenomenology of the patient, which is going to tell you about the symptomatogenic zone. So you could look at this symptomatogenic zone by the history. Is there an aura or not? You could look at the mobile phone videos and then hypothesize the symptomatogenic zone. Or you could do a video EEG And the video EEG semiology, which you see there, will also tell you the symptomatogenic zone, which is what is producing symptoms. But you really don't need to excise the whole symptomatogenic zone, otherwise you're going to end up with a lot of deficits. Particularly here, it's a left frontal dysplasia. So you need to look at what is the maximum limit of the symptomatogenic zone, which is the irritative zone. And so this irritative zone we determine by the lab downstairs, which is the interictal EEG. So the interictal EEG tells us the limits of the zone. It will not tell us accurately where the ictal onset is, but it will tell us around that area. So that is determined by the interictal EEG. The irritative zone is also determined by the interictal Spect and the PET. Because usually we don't have an ictal PET. It's usually always an interictal PET. So those tell us the interictal zone. The interictal zone is also determined by the interictal MEG. Then, of course, but in a tier 1 center where you all start off your programs, you may not have a MEG. You have to have an epilepsy protocol MRI, which is a 1 millimeter thin MRI. And then you have to have a good neuropsychologist who tells you the functional deficit zone. So the functional deficit zone is told by the neuropsychologist. What is the burden of that epileptogenic network? How much deficit is it producing in terms of function? Cognitive function, behavior function, IQ will be told by a neuropsychologist. And the functional deficit zone to a certain extent is also told by the PET. So when you do the PET, you don't find a restricted zone. You find a wider hypometabolism. So that's also picking up the amount of tissue which is affected indirectly by the epileptogenic zone. And of course, you are doing the video EEG. So most of this can be done in a tier 1 center, which is what we were when we started out from 98 to around 2004 or 5. And then, of course, you have further advanced imaging techniques like the ictal Spect, the PET, PET MRI fusion, PET CT fusion, and you have the magnetoencephalography. So this is going to tell us exactly where that subtle lesion or where the epileptogenic zone is in a normal MRI or multiple lesion MRI or discordant video EEG and MRI findings. Sometimes, despite having all this, you have to put in electrodes to determine the exact area, particularly if the lesion is around the eloquent cortex. You don't want to be resecting, maximizing your resections. So you have to do an invasive EEG, which we know now as the SEEG. So basically, these are investigations which are done in a tier 2 center. Is that clear? Now, this all requires a team, and I'm proud to say, as Professor Padma mentioned, we have an excellent team with neuroradiologist Dr. Gaikwad, nuclear medicine Professor Bal, of course, and Madhvi, and we have neurosurgery Dr. Chandra and Dr. Ramesh, and Bhargavi was with us. We have neuropsychologists, Ashima, we have epilepsy surgery fellows, and then we have a whole lot of research team and MEG staff which are working on the MEG. Each MEG analysis takes roughly about 6 to 8 hours. Why are we doing all this? We are doing all this with a quest to improve the quality of life of people with drug-resistant epilepsy, which is possible if you halt their seizures. They can go back to catching up what their activities were, and many of you are following up patients in the OPD. I make sure all of you are there seeing patients on follow-up, and you would realize that some of them who are seizure controlled following surgery are doing very well. And also, since the drugs and the seizures impact the memory and intelligence, once you remove that network, the memory and intelligence also does improve, unless it's a double hit to a dominant temporal lobe, which we have to counsel for. Now, as I told you, the PET and Spect were the initial investigations which we started out with, thanks to the nuclear medicine team. We did long-term follow-ups for 8 years, and you can see that our follow-ups and outcomes were as good as that in the West. So for temporal lobe surgeries, the outcomes over 8 years were 75% seizure freedom. And for extratemporal, they were little less, which is 58% seizure freedom. We also had methods before the MEG came to fuse all the possible modalities, the MRI, the PET, the Spect, and also do an intra-op electrocorticography where we see these repetitive spikes. This is done in the OR, and now we have it linked to my office computer, so I just have to sit at the office and see it. and we resect whatever is possible, which is electrocorticographic guided. When we see the spikes are eliminated, we know the enough of the tissue has been eliminated. Now, just to go back to, as I told you, we had the PET, we had the Spect, we have the MRI. Now, you can see here the x-axis tells us the resolution over time. And epileptogenesis is really a very quick phenomenon. It occurs in microseconds. So you can see the spatial resolution here. And if you look at the best temporal resolution, that is in times of detection by speed or point detection, MEG outnumbers both the PET and the SPECT, and to a certain extent the EEG also, especially if you're doing high density EEG. And if you look at the spatial resolution is at par with probably the PET. So really, to determine a fast activity like an epileptogenesis, MEG is a highly accurate tools in terms of the temporal resolution and to a certain extent the spatial resolution. Now, when you add the source imaging with the MEG, that is when you add the MRI with the MEG, this goes up much higher. So what's the physics behind the MEG and why are we talking about it? So basically, epileptogenesis is a movement of an electrical charge, and there's something known as Maxwell's equations. And there is a depolarization and repolarization, and there's a translocation of ions, the movement of charge, and there is a generation of a magnetic field, which is what is detected by inverse modeling. And this modeling is what takes us time. And the advantage of magnetic imaging over EEG is that it has very little attenuation through the scalp or volume conduction. So it's going to give you very faithful signals. Now, even before MEG was detected, the Indians knew in their 1 rupee coin that there is something known as the right hand thumb rule. That is the direction of the current flow, which is marked by the thumb, is perpendicular to the direction of the clockwise movement of the electrical charge or the magnetic charge in this case. And so this is the net output, which was depicted in our 1 rupee coin before even the MEG came into, place. And we also had it in place in our 2 rupee coin, where you have this pointing finger, which is the direction of the magnetic field, which is by Fleming's right hand rule. So these are the two principles which we follow for MEG. Now, when will we do MEG? So we did a systematic review and we looked at all the evidence way back in 2014. And wherever you have to determine function, remember we are doing epilepsy surgery to preserve function. So you're going to do the MEG. H is highly recommended. So you're going to do MEG, which is here in the first column. So it's highly recommended. Wherever you have a normal MRI, where your MRI is failing to pick up things, or the first read of the MRI, go back to first read of the MRI is normal, there also it's highly recommended. And wherever you have lesions which are focal polymicrogyric lesions, there also it's highly recommended, because polymicrogyria has a lot of convolutions, and we'll come to learn that the MEG has a very great advantage in convoluted cortex. Also, when you have multiple lesions like tuberous sclerosis or multiple clastic lesions, which we see, gliosis, multiple areas, there also MEG is highly recommended. As well as in FCDs type 1, where the margins are not clear. Now, a type 2 FCD has very clear margins because it has got these balloon cells in it. But the type 1 is just dysmorphic and disorganized neurons. So it looks very subtle and very dirty on the MRI. And there again, the MEG is highly recommended. So essentially, what we laid out in this systematic review by the International League was that there are certain mandatory testings which need to be done, particularly if your patient is non-lesional, if they're divergent or discordant video EEG and MRI findings, if it is multi-lesional, and of course, if your lesion is near the eloquent cortex, before you even think of resecting it, and you need to do a magnetic source imaging. Now, this was in 2014, but even before 2014, in 2010, we laid out the role of MEG in our, guidelines for epilepsy for India. The American Academy of Neurology in 2009 outlaid a position statement on the utility of MEG. And It covers the pros and cons. It's a very good read of MEG, EEG, intracranial EEG, functional MRI. And it also acknowledged that doing a MEG helped us decide placements of intracranial EEG electrodes. It changed the overall decisions whether to operate or not operate, and if to operate, where to operate. And it performed better than PET and Spect. And it had positive impact on non-epilepsy surgery outcomes also. So this is a good review for the residents to read by Siddharth and Robert Knowlton, who's done a lot of work on MEG. So wherever you find that there is discordant data on your video EEG and MRI, where you're not getting a clear hypothesis for the ictal onsets, wherever there are lesions around convoluted or deep-seated cortex like insula, wherever it is near the midline, interhemispheric, affected onsets, wherever it is a large lesion, wherever you need to have a guidance to where to put the SEG electrodes, wherever you have secondary bilateral synchrony like you have in the patient in the private ward right now, and of course, wherever you have, anterior temporal abnormality, which is suggestive of polar etiology, and distorted cortex. So where will you see distorted cortex? Post-traumatic cortex and post-surgery cortex. So these were the areas in which you would want to do the MEG. Now, so how does MEG, obtain these magnetic signals? Unfortunately, we aren't even aware of the magnetic, effect or magnetization. The whole globe has, 2 poles and magnetic poles to it. Now, basically, the MEG has 2 components to it. It has a magnetometer and it has a gradiometer. And it picks up magnetic signals which are as minute as 10 to the power of -9 to 10 to the power of -15. You can't even imagine. And the first clinical MEG was in 1968, detected by David Cohen. So this is just to show you the Earth's magnetism is around 10 to the power of -4. And if you look at the brain spontaneous magnetic fields, which is what we're detecting, it's like 10 to the power of -9 to 10 to the power of -15. And for this, you need a device which is known as a squid, which we'll be talking about. And you need a flux meter. Hence, you need to have it in an area which cannot be near your metro stations. It cannot be near highways. Unfortunately, AIIMS is near both of those. And it has to be in a secluded area, which is why it is situated at the National Brain Research Center, which is an ideal picnic spot for the residents. Whenever you want to see the MEG, you can let me know. And this is our staff here, very dedicated team of staff we have, which, there are 10 beds there where the patient goes and stays there. And it's done for about 3 hours. So we're detecting these magnetic dipoles, which are basically positive and negative, as you see in a battery. And this is depicted in a map like this. So you'll have a negative and you'll have a positive, and then you'll have the direction of current flow, which is like this. So, and then it's detected on a spot there. I'll show you a few more examples. So what is the advantage of MEG over the EEG? So the MEG essentially detects dipoles which are tangential to the surface of the brain. They are not radial. So this is the surface of the brain. So is there more surface on the surface of the brain, or is there more real estate in the gyri and sulci? So you have more real estate of the brain in the gyri and sulci. So it's going to detect much more activity because you are going to have convoluted cortex and you're going to have the tangential dipoles which are generated by the epileptogenic lesion in this, buried cortex. So this is just to show you that the MEG is going to pick up a signal which is starting here and then spreading to the cortex much more early and much more easily than the EEG, which comes in much late. So basically, these are just to show you the tangential dipoles. The radial dipoles will be here, and this is your magnetometer and gradiometer, which is picking up the currents and deflecting it as a potential on the graph. For doing the MEG, we also do a high density EEG, and the patient is digitized to this EEG. The EEG cap has exact locations so that we can help it fuse with the MRI, and this is a very labor intensive process. So as I told you, we have the squid, we're going to talk about it, and this has to be cooled down, just like Dr. Manjari needs to be cooled down at times. So helium has to be applied here, and there is a dipole which is generated, which is picked up. So we'll go through that. So the first instrument is the flux transformer, and we have the magnetometer M, and we have two gradiometers. So they are different in their pickups, and they are, basically superconducting wires to pick up the signal very fast, maintained in liquid helium. So you can't, if you touch that liquid helium, your hand is going to have a frostbite and you'll need an amputation. It's in a protected case, which is there. So basically you've heard of MG. MG is a motor company, but here for MEG, it's the magnetometer and the gradiometer. So why are these two needed? So the magnetometer tells us the exact point or the precise location, and it's very sensitive to deep brain tissue. So this is the eggshell magnetometer. Whereas the gradiometer tells us the rate of change. So it's not a point, it's a one point to another point. So a rate of change in the magnetic potential between point A and point B. And it is very good in noise reduction. So any of your skull missing, or your, thickness of the skull is increased, or there's a bandage or whatever, it's going to just remove all that noise, and it's going to magnify very weak signals. So you really need both. And what we have in the MEG, which we have, is a planar gradiometer, not a serial or eggshell gradiometer. Now we select the epileptiforms when we see the MEG, and the selection is based on the rise time. So when we have the discharge, the technologists pick up those rapid rise time. So from the baseline to the rise, it has to occur with a goodness of fit of 90% very quickly. So that's how we pick up these signals, and the spike is the same, 70 milliseconds or less. Now, how do you compare the EEG with the MEG? It's very important to understand that we have been taught in EEG that the EEG picks up signals over a 6 centimeter cortex area. So 6 centimeter by one study, and another study by Cooper in 2006 was 10 centimeter. So 10 centimeters is a really wide area. You don't want your surgeon removing 10 centimeters of the brain. Whereas the MEG cuts it down to almost half, 3 to 4 centimeter. And recent studies, which I'll show you, have said it picks up to 1 centimeter. So it can pick up activity from cortical areas that are 3 to 10 times smaller than your EEG. And that's how it scores over the EEG. However, both MEG and EEG are complementary. You're not going to be doing MEG in all your patients, as I told you. And the MEG is going to give you about the radial dipoles, whereas the EEG is going to give you both radial as well as tangential dipoles. So after doing all of that, the technologist and myself do a visual inspection of the raw data. We do a pre-processing, we remove the filters, we process the data, and then we pick up the discharges, then we register it with the head model, and then we put it onto the source. The whole process takes my technologists and ourselves about 6 to 8 hours for a single patient. Forget the 3 hours of recording. Then we pre-process it, and we see the signal to noise ratio. Signal to noise ratio is very, very important. If you have a very low signal and high noise, you're not going to get a good output, and I'll let you know how. And then we develop a topographic map, and you can see here these spikes which are picked up as compared to the other areas. So this is the signal. This is the spike being picked up here, and the noise in the current system is low. So you will develop a ratio, and that is the SNR ratio. Then you analyze it by various methods. By, the commonest which we use is, of course, the ECD, which is the equivalent current dipole. And we also use the distributed source modeling. Now, this is involving a lot of physics, etc. So, boundary element model and all also use, but we find the inverse modeling to be superior to the others. Now, the equivalent current dipole gives us the spatial coordinates in the XYZ axis, and that's why we rely on this. Whereas the distributed source modeling is something like, it shows us the distribution where the point is maximum and how it is depleting over time, the signal. So that is done by the Curry analysis. So this is the spike we've got, and this is the dipole, negative, positive. This is the direction of the flow, and the rise time has to be within 90% goodness of it. When we do the SNR for this signal, the SNR is 6.1 and the goodness of it is 90. So that is a good SNR. It's more than half. Then we define a cluster. So we find a cluster of these spikes in an area. So wherever you find 6 or more spikes in one area, we call it a cluster, and they have to be within 1 centimeter of each other. So that's when we say it is significant. Otherwise, you can have dispersed dipoles all over the brain. So that's not significant. When you find the cluster of more than 6 dipoles, which are clustered and preferably a tight cluster and within 1 centimeter of the area. This is just to show you another with the rise time, good rise time. And you find the SNR of 4.6, it's slightly suboptimal. And so you find the cluster is a bit scattered, but the goodness of fit is 90. So I would still say this is quite reliable. And then there's another one here. And you find here the SNR is really dropped to 2.9. And you can see the scattering has increased. So it's not within 1 centimeter. So you are going to take this with a pinch of salt. You're not going to, jump and say that everything is here. So there are several new methods. We are now analyzing high frequency oscillations also. And we have a research grant with the UCL, which is ongoing. And one of our PhDs from here is there who's doing all the analysis at UCL. So it picks up activity above 80 Hertz. And you can see here in one of our patients where above 80 Hertz activity is here. And so the high frequency oscillation by the distributed source modeling. This is what is distributed source modeling. The peak is here and then it falls apart gradually. So is around the neocortical areas, which is also a good, way to analyze the MEGs. So this is just to show you the visual inspection of raw data. It's 306 channels. So if you're getting bored with just seeing 18 and 12 channels on the interictal EEG, just imagine 306 channels. Then you do a pre-processing, filtering, artifact, abnormal discharge, identification. More than half of my day goes in this. Then you do a co-registration with the head model. So these are your points which were digitized when the technician was digitizing these points, and these are then fused with the MRI. So that you have the exact location and you don't have a displacement. Then you have a topographic map, then you have a source imaging, dipole fit, you have a source localization with the large lesion. So what this is essentially telling you is you are seeing the lesion here. It is on the mesial surface and it's on the left side. So remember, MEG left is left and right is right. And this is towards the inner surface. So the surgeon can decide where to go based on this plus the ictal spect findings. This is the distributed source modeling, DSM, and you can see here you're seeing number of spikes coming in, and this is the filtered data, and then this is the EEG. So we have a simultaneous EEG also, high density EEG, and then you pick up spikes of similar nature. So you group the mischievous residents in one group, the good residents in one group, like that you pick up the spikes. So similar spikes, one group, okay? So all the pinks are one similar group. Then blue is another morphology spike. So not only you're looking at one morphology, you're picking up several morphology spikes. So then you pick up these different spikes in different groups and then you analyze. This is a third spike. So some patients have 100 types of morphology of spikes and it becomes very painful. So you can see how repetitive these spikes as compared to the previous two. So you have to account for each of these different spikes because they may be coming from different areas. So you have to group them together. We've done more than 2,500 now, of course, and we get patients from overseas, from New Zealand, from Bangladesh, Pakistan, etc., and from all over the country. We looked at the diagnostic added value of interictal MEG source imaging in the pre-surgical evaluation, and this was a prospective study. And of course, we wanted to answer that if the MSI avoided implantation of intracranial electrodes. Remember, intracranial electrodes are an out-of-pocket expenditure for the patient, whereas the MEG is free, provided by the government of India. So really, you are having an out-of-pocket expenditure of SEG, and one SEG electrode costs 60,000 rupees. It's another matter that we have free electrodes because of the research protocol. And of course, we wanted to also find out whether the MSI indicated additional cortical substrates for implantation. So the workup was the usual. You people are very familiar with the workup. We screened about 215 patients. Some of them had to be eliminated because of exclusion criteria. And then eligible 102. And then about 78 underwent a MSI localized with concordant resected volume and MSI localized with discordant resected volume. You can see here the angle outcomes, which is angle 1, which is complete seizure freedom, was higher where you had a MSI concordance with your resected volumes. So proving that it does affect your outcomes. So this is just how we, relate the concordance. Concordance would mean within the lesion and the MEG is there, then partial overlap and then distance. And you can see here that if the video EEG and MRI was concordant, it was a good sign. And if the MRI and MSI were concordant, it was again so with the MRI and the MSI, it was again a very good sign for good outcomes. So basically what we found in our data was that the MEG provided us non-redundant information in about a third of our patients. Whenever you send the patient to MEG and the patient asks, what is MEG? You can say 30% chance that you could answer the problem which you have based on this. And it prevented in about 20% intracranial implantments, and in about 76% of the patients who underwent a surgical resection based on the sublobar concordance of the MSI. And the diagnostic odds for a angle 1 was 2.3 with a confidence interval which is shown here. So this is just to show you how a basifrontal lesion was localized by the MSI which was missed by our MRI. So this is a diagrammatic representation of the same. Then we also looked about 10% of our patients. We've done more than 2,000 now. So about 200 of our patients had a seizure because we are recording for 3 hours. So they had a seizure while the MEG was going on. And this was the initial data analysis which Bhargavi did. And here, of course, we wanted to see if the ictal MEG source localization added information, beyond the interictal MEG. So because you're having a seizing patient there, and we can see here the ictal onsets which are picked up with increasing activity of the discharge, and this is an insular localization, and this patient indeed had an insular cortical dysplasia which was resected on the right side. So the ictal MEG influenced decisions in another third. So the answer is a third of our patients converted phase 2 decisions to phase 1. So we obviated implantations in about another 30%. And it also gave us the ictal onset zones, whereas the interictal MEG gives us the irritative zone. So it was additionally useful. I'd call upon Dr. Madhvi to talk about the role of comparing MEG with Spect. All of you know about Spect, and she will be telling us about this.
Thank you, ma'am. Just moving on with another study in which basically we looked at the comparative contribution of MEG and Spect in preoperative localization for epilepsy surgery, which was a prospective blinded study between 2015 and 2017. Now, as ma'am has told you, we've been doing Spect for over 2 decades now. And that is why the need for this study where we looked at the contribution and whether MEG, this study was basically designed to evaluate if MEG could offer an alternative to ictal Spect for pre-surgical evaluations in persons with drug-refractory epilepsy. We'll come to the limitations of Spect and why we actually needed to look at this alternative. So this was, as I told you, a prospective study between 2015 and 17. All patients had undergone the routine investigations of scalp EEG, MRI, and video EEG monitoring of seizures. MEG and Spect were additional non-invasive investigations that were performed under the following conditions that was decided by the neurologist based on the recommendations of the Pediatric Epilepsy Surgery Task Force of the International League Against Epilepsy. The decision to proceed with intracranial EEG monitoring or SEEG placements or directly to resective surgery was then based on non-invasive preoperative investigations that they were considered during the planning for surgery. So these patients then who underwent surgery were followed up for 36 months, and the surgical outcomes of seizure freedom were assessed using Engel scores, with Engel 1 graded as good outcomes, and the results were also separately noted for Engel 1A. The concordance was taken as concordance between MEG and surgical outcome, which was assessed at both lobar and sublobar level, whereas the Spect we looked at concordance only at a lobar level because we can't go to sublobar levels in case of Spect. And concordance of these investigations with the resected volume was confirmed using individual postoperative CT scans. If the investigation localized to a defined lobe or a sublobe of the brain and it enabled resection of an overlapping region of the brain, it was deemed as concordant. And if the localization was in a different region of the brain or hemisphere and there was no overlap with the resected volume at the lobar or sublobar level, it was termed as discordant. So a total of 102 patients were included. 51 were temporal lobe epilepsies and 51 extratemporal lobe epilepsies. 89 patients, that means around 87 patients had an Engel class 1 outcome, and 57 of which were classified as having Engel 1A, that is around 50 while 13 patients reported class 2, 3 or 4 outcomes after 36 months of follow-up. MEG was done in 101 patients and SPECT could be done in only 57 patients. So we're talking of this period of 15 to 17 where we could include of a total 102 patients included. MEG could be done in 101, SPECT could be done in 57. Of this 57 specs, localization in SPECT was only in 42 and SPECT was non-localizing in 15% patients. That means in around 26% patients, we were non-localizing. So this is basically the baseline parameters of the patients where you can see that the duration of epilepsy for the temporal lobe, there were around equivalent numbers of temporal and extratemporal epilepsies. And of course, as seen, the commonest in temporal lobe epilepsies were the mesial temporal sclerosis and focal cortical dysplasias, where for extratemporal, the commonest pathology was focal cortical dysplasias. Now, when we looked at the diagnostic performance, so basically the diagnostic performance of MEG and SPECT was taken against the surgical outcomes. That is, when you resected the localized area with the surgically resected area and the patient had a good outcome, it was taken as a true positive. And when we looked at the diagnostic performance of MEG and SPECT, you can see this is at a sublobar level. So naturally, the MEG was not as good, slightly lower than that of SPECT, and the odds ratio of SPECT was better than that of MEG. Whereas in angle 1A outcomes, again, the same, similar, but this was at a sublobar level where MEG does better. And when we looked at the lobar level, now this is more comparable. So here you can see there is not much difference between the sensitivity of MEG and SPECT, while the diagnostic odds ratio of SPECT was better than MEG. Similarly, for angle 1 outcome, the sensitivities were really similar, but the diagnostic odds ratio for SPECT was better. So when it comes to also, as I told you that MEG is also very useful for deciding the SEEG placements. So the role of MEG for deciding this was also evaluated, and as expected, where patients had no stereo EEG versus stereo EEG, surgical outcomes were definitely better with stereo EEG placements. And then MEG was useful in deciding the stereo EEG placements in up to 69% of patients, whereas SPECT was useful in only 20% of patients. But that was also because, as you can see, that SPECT was done in a lower number of patients also. We had just 57 patients where we had done SPECT. So SPECT contributed to SEEG placements in only 34%, whereas MEG contributed in 69%. And therefore, the MEG concordance was also a useful factor, a very useful factor in deciding the SEEG placements. So this is an example where you can see that the SPECT localized the voxels of significant hyperperfusion or localization to bilateral frontal lobes, whereas on MEG, there was a clear-cut localization in the right basifrontal region, and the patient could be directly taken up for resective surgery. So even though SPECT reported better diagnostic outcomes as compared to MEG, indicating that even though it is difficult to obtain a SPECT record, once obtained, it may lead to better surgical outcomes. So it is useful. And MEG reported a considerably high odds ratio for good outcome in patients in whom SPECT could not be done. And if you compare it with literature also, MEG has been shown to be more sensitive, in fact, with a good diagnostic odds ratio. In literature, it's around 5.11 for doing MEG. So previous literature again has reported that the diagnostic yield of MEG is either superior or comparable to SPECT. Though SPECT reported a marginally better diagnostic yield than MEG with respect to good angle Caesar outcome in our a subgroup of patients. MEG is easier, therefore, in conclusion, MEG is easier to obtain than SPECT and is a useful diagnostic tool for identifying the epileptogenic focus as well as for SEEG placements. It may be useful in patients who cannot undergo SPECT. Now, the major, I would end this by just telling you about the limitations of SPECT and why we are limited in using this modality, though we've been doing it for more than 2 decades now. Now, that is because there is a limitation in the availability of moly technetium generators. So, we get the moly generator from which we elute technetium, and sometimes this generator is available to us on a weekly basis. And we may not get this because of reactor issues, and because of which we cannot give you technetium for the technetium ECD, that is the perfusion tracer which is used for the perfusion specs. The most important limitation of SPECT is that you have to have a timely injection. So the injection within 10 to 20 seconds of seizure onset is what is recommended. And if you delay the injection, especially in seizures which are very short-lived like frontal lobe seizures, then definitely you will have multiple clusters and it will be difficult to localize the seizure. So, and also the small amount of radiation, there is a very limited amount, keeping in mind that we have a lot of pediatric patients which we are doing. There's a small amount of radiation which is associated with the procedure. It will be contraindicated in epilepsy because of this. And then you need trained personals in the electric, that is in your video EEG labs where you're doing these patients. You have to train the sisters, you have to train the technicians to recognize the seizure onset and inject this tracer as soon as possible within seizure onset. Then of course the cost of the setup, and it may not be available in all centers where you plan to practice epilepsy surgery.
Move on. Thank you, Dr. Madhvi. Based on our experience with the MEG and its use in pre-surgical evaluation, we put up, along with the global forum, addressing human brain mapping issues to preserve eloquent cortices. And this was in the G20 summit in Germany in 2017. So just to give you a review of literature of the role of MEG in pre-surgical evaluation, there's several studies, and Stefan from Europe and Knowlton from US, they are the people who work the maximum. And you can see here that initially the studies started out with very few number of patients, where, because the MEG had just come into a clinical role in a huge way. But even way back in 2003, the MSI could identify the lobe. We're talking about sublobar level at our time in about 90% of the patients. And we also found that Sutherland, who's another very well published author in MEG literature, found the MEG concordant with video EEG in about 66% of patients, and that it influenced intracranial EEG placements in about a third of patients. Knowlton showed a sensitivity of 72% and a specificity of 70% in a seizure-free Engel class 1 outcome. So really, there is a volume of literature out there. Then if you look at the post-surgery outcome, see here that based on various studies, particularly with extratemporal population, here the first study, that 63% was seizure-free with the Engel 1 outcome with the MEG concordance, and another study from Cleveland Clinic on temporal lobe, 90%. So temporal lobe is easier to get higher seizure freedoms, were free of seizures. So another study again from the Cleveland group by Musa et al. Showed that the MEG helped in pre-surgical counseling, and with a 6-year follow-up, 56% of hemispherotomy cases which had undergone a MEG were seizure-free. Then, of course, you find a lot of American Indians publishing in the MEG literature. You find that this study said that, the MEG could identify dipoles within 1 centimeter. Remember, I told you EEG is 10 centimeter, 6 centimeter. MEG is 3 to 4 centimeter, but recent studies have said even down to 1 centimeter. And also connectivity analysis could be done in patients where it was originating and where it was going. This is another study which is published in Brain, which clearly shows us that, based on the interictal spiking volume in MRI negative epilepsy, there was a successful localization of the seizure onset zone with favorable surgical outcomes. Now, if you look at this study where they did a correlation of the MEG with intracranial EEG, so outcomes, again, it was good. And additional value of MEG along with the ICEG, again, when you use both the intracranial EEG and MSI data for resection, the outcomes were associated with good seizure freedom. So to summarize, MEG is extremely useful wherever you have lesions which are around convoluted cortex, around Sylvian fissure, like insula, around the Rolandic cortex, around the mesial, interhemispheric cortex. But you look at frontoorbital. For frontoorbital, it's almost 100% accordance. And then it peters down in the central area, temporal lateral, frontal superior, and temporomesial is the least. So you're really not going to rely too much on temporomesial for MEG, which will be evident by MTS on the MRI. So hopefully I've conveyed to you that at least at our center, we would be doing MEG for these reasons, wherever there's discordance, where there's a normal MRI, where there's a subtle lesion in the MRI, where there are multiple lesions, large lesions, lesions with unclear boundaries, where there is post-op seizure recurrence, and of course, wherever you have bilaterality. So just to summarize the presentation, we'll look at few cases. So here is a young boy who comes with a normal first read of the MRI. I told you we discuss these complex patients almost 4 or 5 or sometimes even 6 times in our epilepsy meeting. And we have to relook at the MRI after all the non-invasive snapshots have come to us. So basically, we first look at it with the video EEG and MRI, and if a PET is done with a PET. But if we don't have that, then we go back and take snapshots of various other investigations like ictal Spect, interictal Spect, PET, and MEG. So you have to tell me what kind of seizure this is. He's sleeping. All the events arise out of sleep. Very brief, arising out of sleep. So hypothesis is frontal. So very brief, all arising out of sleep. He had multiple events, and these were disturbing not only him but also his co-partners in the bed, where his kin would say, his sibs would say, I mean, brother and sister would say he's unable to sleep. So here you're finding a sleep spindle. He's happily sleeping. We know it's arising out of sleep, so it's not a pseudo seizure. It's not an arousal because you see this slowing, and along with the slowing, you find some fast activity intermingling. But really, you're not able to make out in the EEG whether it is right-sided or left-sided. You're finding some kind of bilaterality here. So very difficult to say the laterality on this. Ictal onsets, and then of course, there is this fast activity which comes in, and then this is mixed with artifacts because he keeps squirming on the bed. So the ictal EEG is inconclusive. So here is an indication of possibly you may need to do a MEG because your ictal EEG is not picking up the lateralization nor the localization. All we can say from the semiology that it is frontal. So I will call upon Nikhila, who's had a look at the MRIs in the console in the morning, and she's going to tell us about her MRI. This MRI.
So on this MRI, this 23-year-old male, on the axial flare sections, actually there was nothing abnormal except for bilateral cerebellar atrophy, probably because of his usage of anti-epileptics. Other than that, we have not noticed that there was any cortical thickening or blurring of gray white matter junction or any hippocampus abnormality. But on seeing the PET MR fusion images, we are able to see that there is a region of hypometabolism within the left frontal lobe, left basic frontal lobe.
Thank you, Nick. So really, this is 100% concordance for us. And this made us relook at everything. And of course, we had a MEG dipole by the ECD model, which was also left basifrontal. Now you can see here how frontal lobe can be an aberration in ictal Spect. You find it, the ictal Spect is localizing over the vertex because the seizure occurred for a few seconds, and by the time the staff injects, the seizure is over. So basically, he had left basifrontal. We went back to the MRI. We did not find anything in the MRI except for this hypometabolism. So this was a case where we needed to implant, and we implanted, and this is the surgeon, Dr. Sharath and Dr. Ramesh, implanting. Electrodes were put in the basifrontal, cingulate, insular, with multiple contacts. We have to economize on the electrodes. He had similar events during this. I don't have time because to show you more cases, and you can see here that LB is the left basifrontal. The ictal onsets start in the left basifrontal. So you see this fast focal PFA. This we call as focal PFA. This is left basifrontal, confirming that this normal MRI patient had a left basifrontal onset, and he underwent a resection with a type 1 cortical dysplasia. So this is another patient here, and she comes from all the way from Rajasthan. And you will see here the mother could only know. In fact, many times me and Bhargavi would say that probably she has pseudo seizures. But you can see here her events were so brief, where she jerks her left leg in sleep. Only the mother knows that. So that's the jerk. That's the tonic jerk. And the mother notices it and calls the staff nurse who has gone out. And then she has some dyskinetic movements of her hands and automatisms of both the hands. So there's a tonic jerk of the right lower limb followed by these automatisms. Episodes are very brief. By the time the staff comes, the episode is over. All events occur in sleep. So she is able to tell her name. So again, we would say the localization is frontal. So here you see the sharps which are coming. This is a average montage showing you nice sharps which are in the FP1 electrode. So we got a clue from the EEG that it is FP1 and it evolves in amplitude, falls further, and the average montage picks up this amplitude which was very microscopic. So Nicola will again tell us about the MR.
On this axial T1 sections, again, we are seeing that there is no cortical thickening or no flare hyperintensity in the hippocampi or any blurring of gray white matter junction. This is again MRI negative, reported as a normal MRI.
Yeah, so it was reported as normal MRI, and so we just went ahead with doing further investigations. And those investigations included a MEG. And again, lo and behold, by the distributed source modeling, it was in the frontal and spreading to the leg area. So that is why the tonic jerk was there. So you find the propagation there of the spike with the dipoles. And when you did a PET CT showed a hypometabolism in the basifrontal area. Now, if you go back and Nikhila, you look at the MRI again, which is what we did. And you find, after looking at the MEG and after looking at the PET, you find that the white matter in the gyrus rectus area is going up to the bulb in the right side. But on the left side,
there is some amount of cortical.
Yeah, there is this cortical thickening, and this, by all of us, we went through this patient so many times, was missed by me, it was missed by everybody. So when we found the MEG, we went back to the MRI. The first case was negative MRI, but the second case we found on a relook of the MRI in that suspicious area, which we may have hurriedly overlooked, there was definitely a thickening with a difference. The white matter was truncating here, whereas it was seen very extensively over here. This is, again, she underwent a resection. She is seizure free and gone back to college. So then we go on to the third patient, who was actually, of course, we placed an SEG in her again, and we can find here that she has the seizures coming from the basifrontal. And this is again LB, and here it evolves and spreads not just to the basifrontal but also the insula. The last patient which I'm presenting, as there are only 5, there are lots of cases, but this is one of them. She was a surgical failure at a center which was operated her in the south of India, and she came to us with a persistence of seizures. And her seizure semiology didn't look occipital at all, which was what she was operated for. But on repeated asking, the seizure semiology looked very temporal. So to keep observing her, she's sitting in bed. She's wandering around, looking around. So you see her right hand now going out, and then she will have a posturing of the right hand. And the seizures occur in the wake time. So there is a mild postured right hand. The left hand is moving around. The right is relatively immobile. And she's looking around. Seizures still not being noticed by the EMU staff. Were diverted by a naughty boy there. You can see the left hand is moving. The right hand is not moving. So there's a relative immobility of the right hand. And then the sister picks up that the right hand is postured, and they come to test him. She doesn't answer her name. She looks around. So she's not answering them. Still not answering, just looking around. And it's still postured. So it was a pretty prolonged event, unlike the previous 2 events, which were occurring in sleep and very brief. And it goes on and on. So there are only 5 minutes left. So what it picked up was a pre-ictal sharps and spikes, which are seen with a max in the average montage and a maximum amplitude around T3. Now, T3 would mean either mid-temporal or even anterior temporal. So, and it was spilling over to T5 as well as F7, which would mean anterior temporal. And then you see the ictal progression with increase in the repetitiveness. The right side is not involved here. And then it goes on with an ictal progression. So definitely the seizures were coming from the left temporal. The South of India Center had resected a calcific lesion in the occipital lobe. So this is her occipital lobe, a very neat resection. However, there is, Nikhila will tell us.
The glaring finding is the gliotic changes that we are seeing in the parahippocampal gyrus and the lingual gyrus. Some gliotic changes. And
Temporal lobes.
Not scrolling now. Temporal looks normal, but again, while I was looking at today, actually in COT T1 images, I felt that there was a blurring of gray-white matter junction in the left anterior temporal cortex.
Yeah.
Yes, ma'am.
So,
especially on the T1 images, it was
probably what diverted the center was a calcific lesion, which is so common in our country.
That was glaring finding in the.
So the calcific lesion caused a surgery, which failed, and the patient continued to have seizures. And Nikhila picked up this FCD probably in the left temporal lobe. Now remember, I told you MEG is very superior. Thank you, Nikhila. And I'd like to thank Dr. Gaikwad for sending Nikhila here. He was unable to come for an intervention case. So there is this blurring of gray-white matter junction, but you'll really have to be really biased about it. But we did have the semiology, which was suggesting temporal, and the topographic maps did show left temporal. And you can see the cluster which we got was not very focused. I remember I told you it should be within a centimeter or more. However, the dipoles were pretty much localized to the mid-temporal basal region, and they were the equal ECD model also showed a mid-temporal anterior temporal. So we were not sure. We again implanted her, and she had a similar seizure with posturing of the right hand. And you can see here AH is the anterior hippocampus and O is the occipital, because we really didn't want to miss out occipital onset, because the previous center, a very good center, in fact one of the best centers apart from us, had removed the occipital lobe. So we had to implant, economize electrodes and implant occipital and hippocampus. And you can see there's a burst of spikes which is coming before the event from the anterior hippocampus, and then this repetitive burst increases in the SEEG. And as we go along, it evolves only in the hippocampal electrode. So we were very clear by SEG placement, after Nikhila telling us that there is a dysplasia, that the seizures are coming from the hippocampus, and the calcific lesion was actually just a red flag. And in fact, it was actually an innocent bystander in the whole thing. She never had any visual auras in her seizures, and she underwent a resection. Because it was the left side, a functional MRI was done for word generation task, motor speech, comprehension. Her comprehension was pretty much still in the left hemisphere, but had spilled over to the right, though maximally on the left, and her memory was also showing bilateral localization. So she underwent a resection. Yeah. So I'll just terminate with this case. She underwent a resection and she's been seizure free. And it was, of course, a dysplasia, which was a type 1 dysplasia. There were no balloon cells. So there are many cases which we have done to improve our patient outcomes. I'd conclude by saying that again, as I started out, that it is extremely important to understand that what we do here is basically integrate various departments which have to work in a team. We obtain various snapshots in terms of the video EEG, the semiology, the ictal spect, the interictal spect, the PET, and the MEG, and then come to a conclusion as to how many of our patients would absolutely need an intracranial EEG placement, which is expensive in our setup, or in patients whom we can go ahead with surgery straight away. So with this, I'd like to conclude. It's 5 p.m. and if there are any questions, I can answer. I'd like to thank Dr. Gaikwad, Dr. Bal, Dr. Madhvi, Dr. Chandra, Dr. Ramesh, Bhargavi, Nihal, Ravi, and all my senior residents who are perpetually running around getting the MRIs and the specs and the PETs done for our patients. Thank you. I haven't uploaded. Time. Okay. Any questions? Clarifications? If there are no questions, I'll presume I did a very good job. Thank. Ah,
Spect was much more, better than MEG. And considering that Spect is so inexpensive, with that data, do you think it is? How do you just?
so the comparison was actually comparing apples and oranges because we compared the ictal spect with the interictal MEG. Now we know that ictal spect has its limitations, as she showed you a bilateral localization in a frontal lobe, which is so common. And I showed you the other patient who had a vertex localization in a basifrontal lesion. So the patients where MEG was not done was mostly because the injection could not be given or the seizure didn't happen in that time window of the SPECT. And also the fact that many of these patients had these kind of funny reports where they were bilateral or distant from the lesion, which we ultimately resected. So definitely the SPECT is better provided you're able to get it within that 15 seconds of injection, which is a huge challenge. And believe me, despite all our efforts, the staff in the video EG room is continuously changing. I train a set of staff, and after a few months, there is a completely new set of staff. Then you train them, and then they are pulled into some other duty, and then there's another set of staff. So most of the graying of my hair is caused by training of the staff. And it's not easy. Many of them don't pick up the seizure. So even for the testing you saw, they come in quite late. So pickup of the seizure, injection within 15 to 30 seconds is a huge challenge for SPECT. So that is why we did this comparison, that in patients where we are not able to do it due to all these reasons, that is out of time window of the SPECT office hours, and of course the fact that it has not been injected in time, would MEG offer us a solace to hypothesize where the seizures are coming from. Any other question? Yeah, we can have a picnic there. Provided there's time and no COVID. Okay, thank you all. Thank you, faculty. Uh, Dr. Veela, Dr. Deepthi, Dr. Ramesh is here also. Dr. Rajesh.